Good morning, good afternoon, and good evening, everyone, and thank you for attending GoPath Diagnostics' ongoing lecture series. My name is Brandon Cornell, and I am the web coordinator of this event. We're very happy to have a very special presentation this morning by Dr. Russell Vang. But before I formally introduce Dr. Vang, I would like to take a moment to talk about GoPath Diagnostics and should remind you that this webinar is being recorded for future use on our website. GoPath was founded by pathologists as an educational portal, which has grown to over 14,000 members and continues growing daily. We strive to be your leader in pathology web lectures, hosting our ongoing lecture series and the global online medical school pathology course given by Dr. John Benarsic. Not only do we host these lectures from top experts in their fields, but we offer pathologists around the world the opportunity to share information and education through our online conference listings, our discounted book offerings, up-to-date news, journal publications, job postings, and much more. We are proud to offer all of this at zero cost to our members and should emphasize that we would not be able to provide you with these free offerings without the support of our sponsors. So we ask that you take a few moments the next time you're on our site to acknowledge these sponsors by viewing their products and offerings. If any of you are new to our lecture series, these webinars are in real time and offer you, the audience, an interactive approach to online presentations. If you have any questions at any point during this presentation, please submit your question in the question box, and Dr. Benarsic will address your question during the question and answer session following the webinar in the order which they received. Now, I'd like to introduce Dr. Russell Vang. Dr. Vang is Associate Professor of Pathology in the Division of Gynecologic Pathology at the Johns Hopkins Hospital. He holds a secondary appointment in the Department of Gynecology and Obstetrics. Dr. Vang is a member of the Gynecologic Pathology Consultation Service, an in-house gynecologic pathology service, and is director for the in-house gynecologic pathology service. Dr. Vang completed medical school at the University of Texas Southwestern Medical School and went on to complete a residency at the University of Texas Science Center at Houston. Following, he completed a surgical pathology fellowship at Stanford University Medical Center and a gynecologic and breast pathology fellowship at the Armed Forces Institute of Pathology. Dr. Vang is on the editorial board for the International Journal of Gynecologic Pathology, Modern Pathology, and American Journal of Clinical Pathology. His area of research interest includes epithelial tumors of the ovary and fallopian tube, and he has been published nearly 100 times on the subjects of gynecologic pathology. We're very happy to have him here this morning, and with that introduction, Dr. Vang, I'd like to introduce you and turn the screen over to you.
Okay, thank you, Brandon. Okay, so what I'm going to talk about today are serous tumors of the ovary and fallopian tube, and we'll be talking about various important aspects of these tumors. So when we diagnose gynecologic tumors, what we typically use is the World Health Organization, or WHO, classification system. Now, the current edition was published back in 2003, so it's essentially 10 years old at this point. And for those of you that are familiar with them, there are a number of blue books issued by the WHO that contain pathology criteria for all the different organ systems. This is the one we use for the gynecologic tract, and the current or the upcoming version of the GIN WHO is actually going to be spring of 2014. This lecture, what I'm going to do is focus on serous tumors of the ovary and fallopian tube. And in particular, I'll be updating what are the important changes that have taken place since the last version of WHO. We'll also be talking about some important cuts regarding pathogenesis. We'll talk about the criteria. We'll also talk about sets of different diagnoses. And in this lecture, I'll be talking about high-grade serous carcinoma separately from low-grade serous carcinoma. And the reason we'll do that is that biologically, just different tumors, based on what I understand about the pathogenesis of each of these tumors, as well as the molecular of each of these are completely unknown tumors, and I'll talk about each of these in detail in turn. So having said that, for high-grade serous carcinoma, and going back to the 2000 WHO, what we knew at the time regarding of ovarian high-grade serous carcinoma, these were thought to from the ovarian surface limb or ovarian epithelial inclusions. And the potential role that the fallopian tube made for the origin of these tumors was essentially unrecognized during the time of the last WHO. Similarly, pathogenesis fallopian tube high-grade serous carcinoma, this was fully understood. And for serous tubal intraepithelial carcinoma, likewise, this was a pearl lesion, and its role in pathogenesis was not well understood. So for this part of the lecture on serous carcinoma, what I'm going to do is pathogenesis, but we'll also talk exactly how serous tubal intraepithelioma is diagnosed. Now, over the last 7 years or so, a number of papers that have emerged from multiple different academic institutes that have a lot of what we currently understand of pathogenesis of high-grade serous carcinoma. The precursors for this are thought to arise in the middle portion of the fallopian tube, particularly the ovary. And for normal cell types that occur in the fallopian tube, the ciliated cell and the secretory cell, the precursors are actually thought to arise from the secretory cell. So what happens is that some type of cellularly that results in the damage in the tube mucosa. And potentially this may be due to repeat over a woman's lifetime that result in damage, destruction of the ovarian surface septum. And remember that fibreated end of the tube is right on top of the surface septum of the ovary. So there's probably some genotoxic injury that occurs at the fallopian tube fibreated end mucosa. And the lesion that then the sequence is referred to as the P53 signature. Now keep in mind that some authors have proposed that there are steps that occur even before the P53 signature, but for purposes of this lecture, I'll begin with the P53 signature. So this is a lesion that's benign. Cytologically, you don't see any atypia. However, if you were done a P53 stain, you'd see shorter expression. And in one study, slightly over half of these actually had evidence of deeper mutation. But if you do a Ki7 stain to assess the proliferation, these typically have a low Ki67. And as this lesion undergoes transformation and acquires additional molecular abnormalities, this is thought to evolve into serous tubal intraepithelial carcinoma, or STIC. Now, it's considered the earliest morphologic manifestation of high-grade serous carcinoma of the fallopian tube. This is a lesion malignant, so cytologically you get atypia. If you do P53 stain, you will see abnormal patterns of expression, and most all of these have a P53 mutation. Also, if you do a Ki7 stain, typically have an increased or high label index. We do recognize, however, that there are lesions that pathologically and immunohistochemically are the intermediate P53 signature STIC. For descriptive purposes, I'll refer to these as atypical intermediate, and these have gone by different terms of literature, but nonetheless, they're thought to play a transitional step in pathogenesis, and they serve as a bridge between P53 signature with STIC. So as STIC progresses and you acquire stromal invasions, then becomes invasive high-grade serous carcinoma. So to illustrate this whole sequence is a P53, and here's the P53 immunostain, very short stretch of strong overexpression. Now, red arrows are highlighting normal mucosa for comparison, and the black arrowheads are highlighting foci of STIC. So at low power, STIC stands out as being thicker and darker. And on high power, STIC has cellular stratification, nuclear enlargement, hyperchromasia, and loss of cilia. And then in this example, you can see that there's even an irregular luminal surface with detached epithelial clusters that are exfoliating into the lumen of the fallopian tube. Here's the P53 stain on the same case. So here you see diffuse strong expression. And here's the Ki67 showing an increased labeling index. Now as this progresses, you start getting invasion into the stroma. And here's an example of some foci of STIC that are associated with small foci of invasive high-grade serous carcinoma within the stroma of the fallopian tube. And black arrows here are highlighting the foci of stick. And in fact, if you look at the example of stick that's just below center, you can see that it even has direct continuity with invasion into the stroma. So as these microscopic foci of invasion enlarge, you then get a grossly apparent mass composed of a classic invasive high-grade serous carcinoma. So here we have complex papillary architecture, irregular slit-like spaces, and if you were to look at this on high power, you could appreciate high-grade nuclear atypia. These high-grade serous carcinomas of the fallopian tube histologically are essentially identical to their counterparts in the ovary and the peritoneum. So all of this is what we think happens with pathogenesis for fallopian tube high-grade serous carcinoma. So what about ovarian high-grade serous carcinoma? Well, as I mentioned, over the past several years, there have been a lot of papers in the literature that have contributed a lot of knowledge about what we understand regarding pathogenesis of fallopian tube high-grade serous carcinoma, and accordingly it's been proposed that what we've traditionally called ovarian high-grade serous carcinoma may in fact actually really be originating from the fallopian tube. Similarly, if you have a mass composed of high-grade serous carcinoma in the ovary that's large, but you find a stick in the fallopian tube, it's also been suggested that that finding of stick indicates that that ovarian tumor really came from the fallopian tube. So this whole line of thinking is derived from knowledge produced from multiple different academic institutions and based not only on histologic data but also molecular data. In the interest of time, I'm not going into the details for all the separate lines of evidence supporting this concept, but briefly I'll illustrate this. And this is what we think happens with the majority of ovarian high-grade serous carcinoma. So here you can see that the fimbriated end of the fallopian tube is sitting right on top of the ovarian surface. So if you develop a stick in the fimbriated end, which then exfoliates cells that implant onto the ovarian surface, you develop a small high-grade serous carcinoma in the ovary, which then preferentially enlarges and creates a mass. And this would be most likely what we've traditionally called primary ovarian high-grade serous carcinoma. Well, the same thing occurs for what we think happens with the majority of peritoneal high-grade serous carcinomas. Here you can appreciate that the fimbriated end has direct access to the peritoneal cavity, and so if you develop a stick in the fimbriated end, which exfoliates cells that then implant onto the peritoneal serosa, you develop a high-grade serous carcinoma on the peritoneum, which then evolves and enlarges, and that would result in most likely what we've traditionally called primary peritoneal high-grade serous carcinoma. So with regard to this new concept regarding the origin of ovarian high-grade serous carcinoma, the current data in the literature strongly suggests that the majority of ovarian carcinomas and peritoneal carcinomas of high-grade serous type are most likely originating from the fallopian tube. Now, we don't think that necessarily every single high-grade serous carcinoma comes from the tube. We know there are some exceptions. So, for example, we know there are bona fide cases of ovarian serous borderline tumor and ovarian low-grade serous carcinoma that undergo the very rare transformation into high-grade serous carcinoma. It's also important to point out that this whole concept should probably be viewed as a work in progress at this point in time. Not all gynecologic pathologists necessarily accept this line of thinking, but definitely over the past couple of years, it appears that more and more gynecologic pathologists and gynecologic oncologists are becoming accepting of this line of thinking, and undoubtedly over the next couple of years, we're going to continue to see more and more papers emerge in the literature that clarify this whole concept. So now that we have an idea about what stick is and the role that it plays in pathogenesis, what I want to do is spend some time talking about exactly how stick is diagnosed, particularly when that's your only finding in a BRCA prophylactic specimen. So these lesions that I mentioned earlier, the P53 signature, these atypical intermediate lesions, and stick, what's really important to note is that if you look in all the pathology literatures that have been published in the literature, almost every single paper uses different criteria for diagnosing all these lesions, and that obviously presents a problem, and basically that means there are no standardized criteria for diagnosing stick, which obviously is a problem. And partly why it's a problem is that it's difficult to develop very firm working criteria for diagnosing the most minimal example of stick, because stick has a very wide histologic spectrum, and no two sticks look exactly the same. Now, despite that, it's still really important to make sure what you're calling stick is really stick, particularly when you're diagnosing that in a BRCA prophylactic specimen. Because depending on who your clinician is and what hospital center you're at, if you diagnose stick in this setting, you may be buying the patient additional staging procedures. Some patients in the literature have been treated with chemotherapy. And remember that stick is a form of cancer, so there's always going to be that psychological impact of a cancer diagnosis for the patient. So what I want to do is just show a few examples of why stick has a very wide cytologic spectrum or morphologic spectrum. Here's one example at the upper left-hand corner, and then we have normal mucosa in the upper right-hand corner for comparison. So here you can appreciate that the stick has a very sharp transition with normal mucosa. Here the stick has slight stratification, the luminal surface is flat, but you have complete loss of cilia. You also have nuclear enlargement, hyperchromasia, and nuclear molding. In this example, we have stick at the top and normal mucosa at the bottom for comparison. And again, just like the last example, you have nuclear enlargement, nuclear rounding, and epithelial stratification. But unlike the last example, instead of having a very flat luminal surface, here you have a very serrated, irregular surface. And instead of having hyperchromatic nuclei like in the last example, here your chromatin is a lot paler and more fine, but nonetheless the chromatin is still irregularly distributed. And then in this final example, the top and bottom in this photo actually came from the same fallopian tube. So in the top example of stick, the luminal surface is very irregular and serrated, whereas in the bottom it's very flat and smooth. In the top, the nuclei are smaller and more hyperchromatic, whereas in the bottom, the nuclei are larger and more pale. And you can even appreciate in the bottom a vesicular appearance to the nuclei with prominent nucleoli and even a single mitotic figure. So just a few examples to show the morphologic spectrum of stick. Now, as you might imagine, what's stick to one pathologist may not necessarily be stick to another pathologist. So a couple of inter-observer reproducibility studies have already been published measuring the level of inter-observer agreement between pathologists when diagnosing stick based on just morphology alone. In this first study here, this was from the Brigham Hospital, and in this study they show that even among the experienced pathologists in that study, the level of inter-observer agreement was only in the fair to good range. And then subsequent to that, we did a multi-institutional study that was based at Johns Hopkins, and in our study we showed that the level of inter-observer agreement was only in the fair range. So basically these two studies point out the problem that the diagnosis of stick is not going to be highly reproducible when based only on the H&E slide. Now, in that Hopkins study that I mentioned above, one of the other aims of that study was to address the question of whether we can make a more reproducible diagnosis if we include in some objective information like immunohistochemistry. So in that study, we actually developed a working diagnostic algorithm that pathologists can use for diagnosing stick that incorporates morphology coupled with immunohistochemistry. So more specifically, for this algorithm, we do a combined assessment of the histologic stain based on H&E staining, as well as immunostains for P53 and Ki67. And so what I want to do now is spend some time explaining exactly how this algorithm works and what are the criteria. And the first immunostain we use is P53. And we simply score this as either an abnormal or wild type pattern. And for the abnormal pattern, there's actually two patterns to be familiar with because each of these correlate with a P53 mutation. The first pattern is the one that I think most pathologists are familiar with. This is the more common pattern. And this is one where you get diffuse strong expression. And this correlates with a particular type of P53 mutation. Now, less commonly, you get another pattern, and I think not as many pathologists may be familiar with this, but this is a special pattern where you have complete loss of expression within your focus of interest. So it's essentially a 0% labeling index within your focus of interest, and this is due to a different type of P53 mutation, but it's really important that this pattern doesn't just simply get considered as negative. And to illustrate that, if you look at any normal tissue, and here we have normal endometrium, if you take any normal tissue and you do a P53 stain, typically what you'll see is rare scattered weakly staining cells. And that's what should be considered a real negative. This is the type of pattern that correlates with a wild type P53. This is in contrast to that special pattern where you have complete loss of expression within your focus of interest, provided that you have an internal control somewhere on the slide, and I'll show an example illustrating that a little bit later. The other stain we use is key 67, and for this one we simply score this as low or high. The cutoff we use is 10% positive cells within your focus of interest, and the reason we use this 10% cutoff is that based on a study we did at Hopkins looking at key 67 staining in fallopian tubes, normal fallopian tubes typically have a very low staining index, on average about 2%, and in the same study sticks had a much higher labeling index, about 36% on average, but nonetheless all the sticks in that study were above 10%. Also, in two separate reproducibility studies we did at Hopkins testing out this algorithm, we showed that the 10% cutoff for key 67 has a substantial level of inter-observer agreement. So this 10% cutoff is based on not only biologically valid data, but also in practice it works and it's easy to apply. So this is the algorithm that I referred to. This might look somewhat complex, but it's actually very simple, and I'll walk everybody through this. So the first thing to do is to assess the morphology and determine whether morphologically you think this is unequivocal for stick, suspicious for stick, or not suspicious for stick. Now, as I mentioned earlier, it's really impossible to come up with working morphologic criteria for stick because it's just not reproducible. So instead of using any specific morphologic criteria for this part of the algorithm, instead we just use various combinations of histologic features that I illustrated earlier, and so you essentially develop a gestalt impression in terms of whether you think morphologically it's unequivocal for stick, suspicious for stick, or not suspicious for stick. Next, you look at the coordinate expression profile of P53 and key 67, and then depending on your result, you end up with one of four diagnoses that you see at the far right. So stick is in red, these atypical intermediate lesions are in blue, normal or reactive is in yellow, and then the P53 signature is in purple. Now, one of the beauties of this algorithm is that even though one pathologist might think the case is morphologically unequivocal for stick and another pathologist might think the same case is only morphologically suspicious for stick, you have to use the immunohistochemistry in the same exact fashion to arrive at a final diagnosis of stick. And this is a redundancy that's specifically built into this algorithm to compensate for that imperfection in morphology. Now, of all these diagnoses on the far right, the only one that's really clinically important to diagnose is stick, and this is basically how you diagnose stick. You need to have all three of these criteria present. You need to have atypia, whether you think it's morphologically unequivocal for stick or morphologically suspicious for stick. You need to have an abnormal P53 pattern, and it's either of those two patterns that I mentioned, either that all or none pattern of expression, and then you need to have a high key 67 index. So if you have all three of these criteria present, then you have a reproducible diagnosis of stick. If you have a case that doesn't fulfill all three of these criteria, then it does not qualify as stick. So just to show a few examples from some of these reproducibility studies that we did to show how this algorithm works in practice. Here's an example where your main focus of question is in the center, and then in the upper right and the lower right you have normal mucosa for comparison. So in your focus of concern here, you have slight epithelial stratification, and on higher power you can appreciate that you have nuclear enlargement, nuclear rounding, prominent nucleoli, and even a longitudinal cleavage artifact within the epithelium. And you can really appreciate that atypia when you compare it to the normal mucosa that's at the top of the photo. And so among all the study pathologists on this case, this had a consensus morphology impression of unequivocal for stick. Here is the P53 in the same case. So here we have diffuse strong staining. This had a consensus P53 interpretation of abnormal. And here's the key 67 showing increased staining. And here this had a consensus key 67 interpretation of high. So based on that atypia, that P53, and this key 67, this case had a consensus final diagnosis of stick. Here's another example. So in this focus, you really don't have much in the way of epithelial stratification, but you do have complete loss of cilia. You have nuclear enlargement, nuclear rounding, abnormal chromatin, and prominent nucleoli. In this case, had a consensus morphology impression of unequivocal for stick. Now, if you look at this P53, the black arrows are highlighting the same focus I showed on the H&E. It's just shot at slightly lower power. And here you see complete loss of expression. So in this case, this had a consensus P53 interpretation of abnormal, and in fact, this was that special 0% labeling index pattern that I referred to. Now, if you look at that same focus highlighted by the black arrows, here is the key 67, and you can see that that dramatically lights up. So this had a consensus key 67 interpretation of high. So based on all of these combined findings, this had a consensus final diagnosis of stick. And then in this last example, here the focus of concern is in the center. Here's a slightly higher power. And in this example, you really don't have much in the way of epithelial stratification. You do have marked loss of cilia. You have some focal nuclear enlargement and some questionable hyperchromasia. So this case had a consensus morphology interpretation of suspicious for stick. Here's the P53. Here you see diffuse strong expression, but in this key 67, this has hardly any staining. So this had a consensus key 67 interpretation of low. So based on all of these combined findings, this had a consensus final diagnosis of atypical. So this is something that did not qualify for a diagnosis of stick. So in terms of using this diagnostic algorithm where you incorporate morphology plus immunohistochemistry, in 2 reproducibility studies we did at Hopkins, we show that now, including immunohistochemistry, you have a substantial level of inter-observer agreement for diagnosing stick, and this is higher than using just morphology alone. So how this would translate into practice, these would be my recommendations for the pathology report if you encounter one of these lesions that you need to work up in a BRCA prophylactic specimen. So in order to diagnose stick, this is best made using morphology coupled with immunostains for P53 and Ki67. If you encounter one of these atypical intermediate lesions, it's best to give a descriptive diagnosis, and then in the comment section of the pathology report, explain to the clinician that this does not qualify as stick. And then for the P53 signature lesion that I mentioned earlier, that term is probably best reserved for academic or research use only. It's best not to put that term in the pathology report because you run the risk of confusing the clinician. So that's basically all I want to talk about for the high-grade serous tumors. What I want to do now is spend the rest of the lecture talking about low-grade serous tumors. And for this part of the lecture, what I want to cover is pathogenesis. We'll also have a lot of discussion regarding diagnostic criteria, and then we'll discuss some selected differential diagnosis. Based on a number of morphology as well as molecular studies, we now have a really good idea about how low-grade serous carcinoma arises. So within this pathway, these start off as a serous cystadenoma or serous adenofibroma, and then with further tumor growth, these develop into a typical serous borderline tumor. With even further tumor growth, these evolve into a micropapillary serous borderline tumor, and then eventually, with invasion into the stroma, these become an invasive low-grade serous carcinoma. At the molecular level, one event that occurs very early is a mutation of either the KRAS, BRAF, or HER2 gene, and this is thought to be a driver mutation for this whole pathway. And this is thought to occur somewhere between the transition of serous cystadenoma into typical serous borderline tumor. And all of these other tumors are linked together by showing increased frequencies of shared allelic imbalances for multiple different chromosomal arms. So now that we know, based on morphology and molecular biology, all these 4 tumors here are linked together as part of the same pathway as a slow, stepwise progression sequence. I want to spend some time talking about serous borderline tumors in detail because I think this can be a very confusing area. And for serous borderline tumor, remember that there are 2 types. There's the typical serous borderline tumor, and there's the micropapillary serous borderline tumor. And also note that there are a number of synonyms that have been used in the literature to describe these same tumors. So for the typical serous borderline tumor, these have also been referred to as typical serous tumor of low malignant potential, or serous LMP, and atypical proliferative serous tumor. For the micropapillary serous borderline tumor, these have also been referred to as micropapillary serous LMP, as well as non-invasive micropapillary or low-grade serous carcinoma. Again, synonyms for the micropapillary serous borderline tumor. Just to illustrate these, this is a typical serous borderline tumor. So here we have a low-grade papillary serous tumor that lacks invasion of the underlying stroma. And with this tumor, we have large papillae that progressively branch into smaller and smaller papillae in a hierarchical fashion that eventually terminate into detached epithelial clusters like you see here. On high power, cytologically, these have small, round, bland, regular nuclei. You don't see significant atypia, and mitotic figures are very infrequent. With the micropapillary serous borderline tumor like we see here, instead of having that progressive hierarchical branching that you get with the typical serous borderline tumor, instead you have large papillae that give an immediate rise to these elongated micropapillary structures. And the quantitative criterion that's used to diagnose this tumor is that you need to have pure micropapillary areas like you see here, involving an area that measures at least 5 millimeters. And the reason this quantitative criterion is used is that in any typical serous borderline tumor, you can sometimes have small amounts of micropapillary growth. And also, for these elongated micropapillary structures that you see here, it's been recommended in the literature that in order to make a more reproducible diagnosis of micropapillary serous borderline tumor, that these elongated structures should be 5 times longer than they are wide. And again, the reason for that is that in any typical serous borderline tumor, you can see small amounts of micropapillarity. On high power, the micropapillary serous borderline tumor has a lot of cytologic overlap with the typical serous borderline tumor. So with this tumor, you have a slight increase in the amount of nuclear size, slight increase in the amount of hyperchromasia, and a slight increase in the nuclear cytoplasmic ratio as compared to the typical serous borderline tumor. But the real distinction between the typical and the micropapillary serous borderline tumor is based on architecture, not cytology. So one of the ongoing controversies regarding serous borderline tumors is whether or not there's really a clinical difference in survival between these two types. And if you look at survival data in the literature, there's a lot of conflicting information, where some papers in the literature show that the micropapillary serous borderline tumor has more aggressive behavior than the typical serous borderline tumor, and that the micropapillary serous borderline tumor has behavior that's much closer to that of an invasive low-grade serous carcinoma compared to that of a typical serous borderline tumor. But not all papers in the literature necessarily support those conclusions. One thing that I think a number of papers actually do show, including a very large population-based study that we're in the process of finishing right now, and that is the micropapillary serous borderline tumor has a significantly higher frequency of advanced stage disease and significantly higher frequency of invasive implants. And that brings up another important topic that I want to discuss in detail for serous borderline tumors, and that's the whole issue of implants. So for the implants that are associated with serous borderline tumors, these are typically classified as non-invasive or invasive. And a take-home point to remember is that the single most important prognostic factor for women with serous borderline tumors is the status of the implants, namely whether they're invasive or not. For diagnosing invasive implants, there are a couple of criteria that have been used in the literature. The most commonly used one, which are the ones I refer to as the traditional criteria, basically state that you need to have infiltration of underlying tissue. And I think most gynecologic pathologists agree with that. Now, one problem is that in occasional staging peritoneal biopsies, sometimes you really don't have enough underlying tissue to assess for infiltration of underlying normal tissue. And for that reason, an alternative set of criteria have been previously proposed, and these are frequently referred to as the expanded criteria. And per these criteria, you can diagnose implants as invasive if they show invasion of the underlying normal tissue, just like the traditional criteria. But also, if you get micropapillary architecture, just like you see in the micropapillary serous borderline tumor, except that now you are in a non-ovarian site. Or if you have solid nests that are surrounded by clear cleft-like spaces. So per the expanded criteria, any of these features here would qualify as invasive implants. Now keep in mind that not all gynecologic pathologists necessarily accept these expanded criteria, but these are the two major sets of criteria that have been commonly used in the literature. And just to illustrate these are non-invasive implants. These are the so-called epithelial type. So here you see papillary epithelial clusters that are associated with psammoma bodies. And these are found within epithelial line spaces, and you don't have invasion of adjacent tissue. Here's another example of non-invasive implants. Here the papillae are larger, and you also have a number of psammoma bodies that are in the process of popping out of the plane of tissue. And again, you don't have invasion of adjacent tissue. Now, one thing to appreciate is that if you look at the epithelial to stromal ratio, commonly in non-invasive implants, this ratio is much more in favor of the stroma rather than the epithelium. And this is basically the converse of what you see with invasive implants. Here's another type of non-invasive implants. This is the so-called desmoplastic type. And at low power, these appear as plaque-like structures on the surface of the omentum or the peritoneal serosa. On higher power, you'll see epithelium embedded within desmoplastic stroma. And if you were in another organ system, this would probably be considered metastatic carcinoma. But in the special setting of serous borderline tumors, when you find these extraovarian lesions, this is accepted as being within the spectrum of non-invasive implants. And again, you can see you have much more epithelium, much more stroma than epithelium. Something we occasionally encounter in desmoplastic non-invasive implants is the finding of these individual cells that have abundant pink cytoplasm. And superficially, this can cause concern for invasion, but most gynecologic pathologists accept this as being within the spectrum of desmoplastic non-invasive implants. In contrast, these are invasive implants. So here you see markedly crowded epithelial nests. These are haphazardly oriented with respect to one another, and qualitatively this appears identical to invasive low-grade serous carcinoma. So here you can appreciate that the epithelial to stroma ratio is much more in favor of the epithelium. Here's another variation of invasive implants. This is the glandular pattern, and it's really important that this does not get mistaken for just florid endosalpingiosis. Here you have glandular structures that are of various size and shape. They're markedly crowded together, and they're haphazardly arranged with respect to one another, and there's even a desmoplastic stroma. In some invasive implants, you can have markedly complex epithelium like you get here, where you produce a cribriform architecture. And then this would be a case that would qualify as invasive implants per the so-called expanded criteria. Here you have solid nests within clear lacunar spaces, and this type of pattern oftentimes is superimposed on true infiltrating patterns. Here's another example of invasive implants that would qualify as such based on the expanded criteria. So here we have micropapillary architecture that resembles what you see in ovarian micropapillary serous borderline tumor, except that here you are now in a peritoneal site. If you look at the interface between the epithelium and the stroma, you can appreciate that you have a very smooth interface, so you don't have infiltration of adjacent tissue per se, but per the expanded criteria, this will qualify as an invasive implant. Another important topic I want to address for ovarian serous borderline tumors is the whole concept of microinvasion. And to diagnose microinvasion within serous borderline tumors, multiple criteria have been used, but the most commonly traditionally used one states that you can have multiple foci within the stroma of a serous borderline tumor, but as long as any individual focus measures smaller than 3 millimeters, then that qualifies as microinvasion rather than invasive carcinoma. A number of years ago, there was an NIH consensus workshop on ovarian borderline tumors, and the proceedings from this workshop are actually published in an issue of Human Pathology from 2004. And in this workshop, it was recognized that there's actually two patterns of microinvasion. The first is the more common one. This is a conventional pattern, and this pattern has cells with abundant eosinophilic cytoplasm. And then less commonly, there's another type that is micropapillary rich, and other authors designate this as the microinvasive carcinoma pattern, except that that type measures less than 3 millimeters in greatest dimension. So this would be an example of the conventional or so-called eosinophilic type. So within the stroma of the serous borderline tumor, you have individual cells or clusters of cells with abundant pink cytoplasm. But foci like this would measure smaller than 3 millimeters. Here is the micropapillary type of microinvasion, which some authors have designated as microinvasive carcinoma, but these foci measure smaller than 3 millimeters. So here within the stroma of the serous borderline tumor, You have a micropapillary-rich architecture with micropapillae that are within clear lacunar spaces, and qualitatively, this looks like an invasive low-grade serous carcinoma, except that it's smaller than 3 millimeters. Now, the really important clinical question is what exactly is the significance of microinvasion? Back in the NIH workshop, it was concluded that for stage 1 serous borderline tumors, microinvasion was thought to not have any adverse effect on prognosis. Now, subsequent to that, there's a paper that came out of Stanford, and this was a study focusing exclusively on microinvasion. And in that paper, they described other histologic patterns that were not formally recognized, like patterns of microinvasion that show simple papillae, cribriform patterns, and the so-called inverted macropapillary pattern. And in this paper, they suggest that microinvasion actually may be a risk factor for disease progression, but they carefully point out that it's really difficult to determine the true natural history of microinvasion because microinvasion tends to covary with other high-risk factors that can be associated with poor prognosis, like invasive implants, unresectable disease, and micropapillary serous borderline tumors. And of all the different types of microinvasion, these authors suggest that the micropapillary type might be the real type of microinvasion that really has higher risk for disease progression compared to the other types of microinvasion. But just like was pointed out in the NIH workshop, these investigators point out that the number of cases reported in the literature that have this micropapillary pattern of microinvasion is really too few to really make any definitive conclusions. So we really don't know what's the real clinical significance of this micropapillary form of microinvasion, although we're really suspicious that this might be the type of microinvasion that really does something to the patient. Another important aspect that I want to discuss in detail is lymph node involvement by serous borderline tumor. If you look at studies that in which women have undergone lymph node sampling, lymph node involvement by serous borderline tumor is actually not uncommon. It's been reported in roughly 20 to 40% of cases. Now, a controversy that's unresolved in literature is exactly why this happens. Some authors have suggested that this is actually a true secondary form of involvement where you have tumor cells from the ovarian tumor that are circulating through the lymph node. But more recently, there are a number of papers in the literature that really strongly suggest that what we've traditionally called lymph node involvement by serous borderline tumor may really in fact be a primary lesion arising out of lymph node endosalpingiosis. Here's a classic example of lymph node involvement by serous borderline tumor. So here in the subcapsular sinus, we have papillary epithelial clusters with psammoma bodies that resembles the serous borderline tumor. And in this other example, here's another pattern we see from time to time. And this is a pattern where the subcapsular sinus is filled up with individual cells that have abundant pink cytoplasm. And actually, if you look to the very left of this photo, you can even see an inclusion of endosalpingiosis. And then in this final example, it's cases like this that make us really suspicious that these are really primary lesions rising out of endosalpingiosis. So based on this degree of architectural complexity, this would qualify as lymph node involvement by serous borderline tumor. But some of these glands that contain epithelial stratification, if you follow the contours of the glands, these are actually consistent with the background of endosalpingiosis. So again, it's cases like this that make us really suspicious that these really may be primary lesions rising out of lymph node endosalpingiosis rather than being a secondary form of involvement. Some take-home points regarding lymph node involvement by serous borderline tumor. First, keep in mind that whenever you encounter this should not be considered metastatic carcinoma. This simply qualifies as FIGO stage 3C serous borderline tumor, and most importantly, this does not adversely affect survival of women with serous borderline tumor. And potentially that might be that these are really primary lesions rising out of lymph nodes rather than a secondary pattern of involvement, but nonetheless it's still an ongoing controversy in the literature. Okay, the last thing I want to discuss for this whole lecture is the differential diagnosis of distinguishing low-grade serous carcinoma from high-grade serous carcinoma. And the distinction between these two tumors is important. It's important for a couple reasons. First, biologically, these are just different tumors. If you consider what we now know about the pathogenesis for each of these tumors, as well as the molecular profiles of these tumors, these are independent, unrelated tumors. But the really important clinical reason is that in most studies, women with low-grade serous carcinoma have higher survival than those with high-grade serous carcinoma. So this is really important for the clinician and the patient. Histologically, there are a number of differences between these two tumors. So architecturally, low-grade serous carcinoma classically has a micropapillary-rich architecture, but we can also see various growth patterns like the so-called inverted macropapillary pattern. With high-grade serous carcinoma, the papillae tend to be larger and more complex. You can also see other growth patterns like glandular patterns, solid patterns, and then in a subset of cases you can have micropapillary-rich patterns that actually mimic a low-grade serous carcinoma. In terms of necrosis, this is very unusual to find in low-grade serous carcinoma. For high-grade serous carcinoma, that's not uncommon at all. So if you find necrosis, that could be a very useful feature because that argues against low-grade serous carcinoma and it helps support a diagnosis of high-grade serous carcinoma. So here's a classic example of an invasive low-grade serous carcinoma. So here we have a micropapillary-rich pattern. There are small micropapillae that are infiltrating through underlying tissue, and on higher power you can appreciate that a number of these micropapillae are within clear lacunar spaces. Here's one of the variants of invasive low-grade serous carcinoma. This is the so-called inverted macropapillary pattern, and here we have large, rather simple papillae, but these are markedly crowded together. They're infiltrating through stroma. They're haphazardly arranged with respect to one another. And on higher power, you can appreciate that these are found within clear lacunar spaces. And the epithelium lining these papillae tends to be very simple rather than complex and stratified. But the real distinction between low versus high-grade serous carcinoma is based on the grading criteria that came out of the MD Anderson Cancer Center, and those are the criteria that we use at Johns Hopkins, and I'll list these here. So based on nuclear features, low-grade serous carcinoma has small nuclei. These are mostly uniform. They're round, regular, and oval. The chromatin is evenly distributed. You can see nuclei, but they tend to be small. In contrast with high-grade serous carcinoma, you have at least a 3-to-1 variation in size and shape of the nuclei. The chromatin is more irregularly distributed. You can see very large nuclei, and you can also see multinucleated tumor giant cells. And these tumor giant cells tend to have large, dark, smudgy chromatin. In terms of mitotic activity, the mitotic index tends to be low in the low-grade tumors, tends to be high in the high-grade tumors. So in the MD Anderson series, based on either the mean or median mitotic index, it was just 4/10 for the low-grade tumors, but much higher, 38/10 for the high-grade tumors. Now, in terms of practical application of these criteria, the primary emphasis should really be on the nuclear features. And in most cases, that's sufficient to separate one from the other. In some cases, there could be some degree of histologic overlap between the two tumors. And then in that setting, you can then look at the mitotic activity as a secondary feature. Now, at Hopkins, we do specific mitotic counts. Instead, we use more of a gestalt impression in terms of the low-grade tumors. These have infrequent mitotic figures that are difficult to find. And for the high-grade tumors, these have easily identifiable, readily abundant mitotic figures. So here's an example of an invasive low-grade serous carcinoma. Here the nuclei are small, they're uniform, round, regular, or oval. The chromatin is evenly distributed, and you do see nuclei, but they tend to be on the small side. Now in contrast, here's a high-grade serous carcinoma. Here you can appreciate the nuclei are much larger. You have a lot more variation in size and shape of the nuclei. The chromatin is much more irregularly distributed. The nuclei are much larger than what you see in the low-grade tumors. And in these large tumor giant cells, these have a very smudgy, dark monster appearance. Here's another example of a high-grade serous carcinoma, and in this case you can see readily identifiable mitotic figures in the single high-powered field. In a low-grade serous carcinoma, you usually should not be able to find mitotic figures that easily. Now, in some cases, you might have enough ambiguity of your morphology that you might need to use an immunohistochemical panel to separate these two tumors from one another. So some useful immunostains include ones like P53. So in the low-grade tumors, you don't see abnormal expression patterns. Instead, you'll see either rare positive cells or a focal or a patchy pattern. With the high-grade serous carcinoma, in most cases, you'll see either a diffuse or a completely absent pattern of expression. Another helpful marker is P16, In the low-grade tumors, you don't see diffuse patterns. Instead, you'll see either negative, focal, or patchy patterns. And in most high-grade serous carcinomas, you'll see a diffuse pattern. Keep in mind that you don't see diffuse expression in every single case of high-grade serous carcinoma, but when you do get diffuse expression of P16, that's an important finding that argues against low-grade serous carcinoma, and it helps support a diagnosis of high-grade serous carcinoma. And then lastly, if you do Ki67, this could be very useful because the proliferation index tends to be low in low-grade tumors, tends to be high in the high-grade tumors. So in the data from this one study that I'm showing for the low-grade tumors, the average Ki67 index was 23%, and it was higher for the high-grade tumors, 55%. So just to show a couple of examples how this can be useful, here's an example of an invasive low-grade serous carcinoma. So here we have a papillary serous tumor that has irregular slit-like spaces and even some micropapillary architecture. And this is the P53 showing a patchy staining pattern. Here's the P16, again, a patchy staining pattern. And the Ki67 here is on the low side. Now in contrast, here is a high-grade serous carcinoma, and in this example this is more of a glandular-rich pattern. Here's the P53 showing diffuse strong staining. Here's the P16, again, diffuse staining, and the Ki67, you can appreciate, is fairly high, and this is much higher than what you would expect for a low-grade serous carcinoma. So that's basically all I want to talk about for this lecture. What I want to do just very briefly is just summarize some of the really important take-home points. So for high-grade serous carcinoma, if these current concepts regarding origin can ultimately be confirmed in future studies, then that would mean that essentially all ovarian and peritoneal high-grade serous carcinomas are really arising from the fallopian tube. And if our aim is eventually to eradicate high-grade serous carcinoma, then really any future clinical studies on prevention need to devise strategies that focus on the fallopian tube because that's where these tumors are probably arising. In order to make a reproducible diagnosis of STIC, what's best is to do H&E stains coupled with immunohistochemistry for P53 and Ki67, because if you rely just on H&E, it's not going to be highly reproducible. For the low-grade serous tumors, the status of the implants, particularly whether they're invasive or not, is the single most important prognostic factor for women with serous borderline tumors. Although there's some controversy regarding the ultimate survival of women with typical micropapillary serous borderline tumors, subdividing serous borderline tumors into these two types is still clinically useful because this helps assess the risk for having extra-ovarian disease and invasive implants, and that's particularly important for cases where the patient did not get staged. As far as the findings of microinvasion in serous borderline tumor, as well as lymph node involvement by a serous borderline tumor, at least currently, these are not thought to adversely affect prognosis. And then lastly, for the differential diagnosis of distinguishing low-grade serous carcinoma from high-grade serous carcinoma, in most cases these can be distinguished by just paying attention to the histologic features of the nuclei. But in some cases there may be histologic overlap, and then you'll need to do immunohistochemistry. And an immunohistochemical panel, including P53, P16, and Ki67, can be very useful. So that's basically all I want to talk about for this lecture. Thanks for your attention, and I'm more than happy to entertain any questions. So Brandon, I'll turn this back over to you.
Dr. Vang, thank you very much. I'm going to switch this over to my screen very quickly. That was an excellent lecture here. Dr. Monarsic, are you on? Hello, Dr. Monarsic.
Thank you. I wanted to thank you for a tremendous presentation. And after looking at these tumors for many, many years and seeing just about everything that you showed, I can now look at them with a completely new light. And I wanted to thank you very much for that.
Oh, good. Thanks. Appreciate it.
I have also been keeping track of the many questions that have appeared. So I hope you're sitting down and have a cup of coffee because we're not going to let you go home yet. Oh, I'm
Okay.
sorry, you are home.
Yeah. So I'm not going anywhere.
The first person to ask a question was Dr. Celestine Trinidad, and I'm going to paraphrase it or read it to you, and then I'm going to mute myself just in case there's a little echo.
Gotcha.
Dr. Trinidad asks, what can be done to differentiate a primary fallopian tube carcinoma that has extended to the ovary versus a primary ovarian carcinoma that has metastasized to the fallopian tube? Will any of the immunohistochemical stains or molecular testing help?
Yeah, as far as that distinction, unfortunately, there's not really any good immunohistochemical or molecular tests that can be done. It's basically based on morphology. There have been criteria that have been proposed in the literature, but I'll warn that they're very arbitrary. Basically, traditionally, if you have involvement of the ovary or the fallopian tube, I think most people traditionally have just considered the ovarian tumors being the primary, because in the past it was thought that fallopian tube primary carcinoma was so rare and that ovarian was so much more common. And traditionally, if the ovarian tumor is larger, I think that's just been traditionally favored as being the primary tumor. So unfortunately, it's going to be a very subjective interpretation in terms of what you think is the bigger tumor. From a clinical standpoint, I think most gynecologic oncologists are not really going to care at all, because in terms of prognosis, in terms of determining stage, and in terms of therapy, they're basically going to be treated the same. So if you have a high-grade serous carcinoma and your differential is it really an ovarian primary or a fallopian tube primary, and you have both sites involved, it's probably not going to be a dilemma. And oftentimes what we do for our in-house cases at Johns Hopkins for that exact scenario is that in the comment, we'll basically tell the clinician that the differential is primary versus fallopian tube origin. We can't tell the difference in this case, and we just leave it at that. Our clinicians understand that dilemma. They're totally fine with it, and we basically leave it at that. In some cases where the same scenario you're describing, but we find a stick, since not everybody accepts this, what we'll do in those situations, for example, say we have like a really big tumor in the ovary and you have minimal involvement of the fallopian tube, but you find the stick, we'll fill out the CAP staging form, and we'll basically do a combined ovary and fallopian tube form, and then in the comment we'll make a comment for the clinician saying that the large size of the ovarian tumor can suggest an ovarian primary, but the finding of a stick can also suggest the possibility of fallopian tube primary, and just leave it at that, and then our clinicians are fine with that. So that's one alternative way to handle that situation. But unfortunately, all of the criteria that you'll find in the textbooks are arbitrary, because they've really never been scientifically validated. So I hope that answers your question.
Thank you very much. I have another second question from Dr. Lai, and he asks, for invasive versus non-invasive implants, do you have a cutoff in terms of number of foci or size of the implants?
We don't use any type of cutoff in terms of the number of implants. With non-invasive implants, you can have numerous foci, so there's not really any quantitative criteria for that. In terms of size of the implants, typically we don't use any size cutoff. And I'll admit that in a lot of cases it sometimes can be very difficult determining whether you have a very big, florid, worrisome non-invasive implant versus a true bona fide invasive implant. If you get something that's really large, I think that should raise your suspicion that potentially that might be an invasive implant, but unfortunately there's not really any developed criteria in terms of size of the lesion. But we have had implants that were, bigger than probably what you see in some. I mean, we've had cases of non-invasive implants that were bigger than some cases of invasive implants that we see, but there's not really any size cutoff, and there's not any criterion for the number of foci. It's really based on qualitative features, whether you have true infiltration of underlying stroma.
Okay, thank you very much. We have a few comments here that are basically thank you, thank you, thank you. So I'll skip over those, but you should know there's a lot of them. And
Okay,
I'll
thank
move
you. Appreciate
down
it.
to the question from Dr. Chung. He says, in grossly unremarkable prophylactically resected fallopian tube, do we submit the entire tube or not?
Yeah, and I'm sorry, that question was for a prophylactic case?
Yes.
Yeah. So if you have a prophylactic salpingo-oophorectomy for somebody who's a BRCA carrier, basically what needs to be done is that all ovarian tissue needs to be submitted for histology, and all fallopian tube tissue needs to be submitted for histology. So definitely everything needs to be submitted for histology. And what's been recommended specifically for the fallopian tube is to amputate off the fimbriated end and then make your sections in the fimbriated end parallel to the long axis of the fallopian tube. And theoretically, that's supposed to help maximize the amount of surface area of mucosa that you're looking at. And then for the tubular or ampullary portion of the fallopian tube, all those cuts should be made perpendicular to the long axis of the fallopian tube. But definitely all fallopian tube tissue and all ovarian tissue needs to be submitted for histology.
Thank you very much. Here's another question from Dr. Liu, who asks, how often do borderline tumors develop into high-grade serous carcinomas?
Yeah, that is a very rare phenomenon. We did a prior study that was actually a multi-institutional collaboration study reporting cases of high-grade serous carcinoma that arose out of a low-grade serous carcinoma. And those were cases that were at the time of surgery. And it was a very small number of cases, which just shows how rare it is. We estimated that based on our files that probably it was 3% of cases, but in all actuality, probably that's an overestimate. And our experience since that time, that paper was published a few years back, but since that time, I think at the time of surgery, when you have a either a serous borderline tumor or a low-grade serous carcinoma, the probability that you'll have a high-grade serous carcinoma arising out of it at the time of surgery, I think is going to be very, very uncommon. I would probably estimate that it's probably less than 1%. It's really uncommon. Now, if you have a serous borderline tumor or a low-grade serous carcinoma and you're asking what's the probability that you're going to have a subsequent high-grade serous carcinoma, I'm not sure that anybody really knows the answer to that, but based on the anecdotal reports that are in the literature, that also appears to be a very uncommon, rare phenomenon. If you get a carcinoma that follows a diagnosis of a serous borderline tumor, almost always it's going to be a low-grade serous carcinoma, but occasionally it will be in the form of a high-grade serous carcinoma, but that will be really rare. And to give you an idea of how rare that is, like I mentioned, we're currently doing a very large population-based study of serous borderline tumors, and we have very long-term follow-up, and we're in the process of actually looking at our cases that were followed by a low-grade serous carcinoma. I don't have that data to provide right now, but based on the Longacre study that came out of Stanford, if you look at their data for serous borderline tumors, the percentage of cases that end up having a subsequent low-grade serous carcinoma, if I remember correctly, I think it's something on the order of just 7% of patients. And those are low-grade serous carcinomas. So you can imagine that the high-grade serous carcinomas are going to be even less common than that. So I think that if you have a serous borderline tumor and then you have a subsequent development of a high-grade serous carcinoma, I'm sure it's probably going to be less than 1% of the cases. So to answer your question, what's your risk of having a high-grade serous carcinoma at the time of having either a serous borderline tumor or low-grade serous carcinoma, or being subsequently followed by that? It's going to be very, very low, probably close to 0%, but it's definitely not 0%. So I hope that answers your question.
It certainly does, and I'm going to throw another very interesting one at you from Dr. Harman. He asks, since STICs are usually diagnosed on prophylactic resections. What is the clinical implication?
And I assume that specifically in the setting of finding it in a prophylactic specimen as opposed to finding it outside of the prophylactic specimen? Am I understanding the question correctly?
It seems that way, yes.
Okay. So in a prophylactic specimen, if you find a stick, and that's your only finding, and you don't find any invasive carcinoma, at least currently, it's not really clear how those patients are supposed to be managed. If you look in the literature, there's only a very small number of patients that have been reported with follow-up data that have only stick as their only finding. And of those small number of patients that have been reported, it doesn't appear that they go on to do anything, although I'm aware of other colleagues that have had anecdotal experiences that say otherwise. Now, part of the problem, since the literature is so limited, some of those patients have been treated with chemotherapy, some haven't, so they haven't been treated in a uniform fashion. So basically, I think it's pretty safe to say that right now, gynecologic pathologists and gynecologic oncologists, we really don't know what's the real natural history of finding just stick by itself in a prophylactic specimen. Now, there have been patients that have been treated with chemotherapy in the literature. That was in the past. I think most oncologists now are probably trying to back off and not give chemotherapy if stick is your only finding. So I can tell you that at Hopkins, what happens in our cases, and we just had one of these in our tumor board yesterday, if we find stick as the only finding, I think our clinicians are preferring to just follow those patients, not give chemotherapy. And I think depending on other risk factors, and it's probably going to vary on an individual case basis, they might consider whether they want to take the patient back to the OR and perhaps do some type of laparoscopic exploration, or perhaps do peritoneal washings or something like that. But I think in terms of chemotherapy, I think currently most people, I think, are probably trying to back off and not give chemotherapy. And so that's probably the best I can answer your question, but I think it's safe to say that right now, if stick is your only finding in a prophylactic specimen, it's not really clear how it should be treated. But other than that, I think most gynecologic oncologists would probably prefer to just follow the patient carefully, counsel the patient whether they want to do any other staging procedure or just a pelvic wash, and probably prefer not to give chemotherapy. So I hope that answers your question.
Thank you, Russell. I have another real zinger thrown at you from GoPath's own Dr. Ken Ikowski, and he's going to ask you, do high-grade or low-grade ovarian serous carcinomas tend to involve endometrium sometimes, and how can these be distinguished from endometrial origin?
Right. I think there's a couple of things to address there. If you have the setting where you have a big staging procedure and the surgeon takes out multiple organs for you to look at, and you find a high-grade serous carcinoma in the ovary, but you also find some tumor in the endometrium, we do encounter that on occasion, and then that therefore raises the possibility of, or the differential diagnosis of, is this really all an ovarian primary that, or fallopian tube primary that has secondary involvement of the endometrium, or was this really an endometrial primary that actually had metastases to the ovarian tumor that clinically mimicked an ovarian primary? And those are the two main things in the differential diagnosis. There's always the theoretical consideration that you may even have two independent primaries of endometrium and ovary or tube, but I think when you're dealing with high-grade serous carcinoma, I think most gynecologic pathologists are going to be reluctant to accept that those are independent primaries. I think most gynecologic pathologists would think that either the endometrium or the ovary is going to be the primary, not that you have independent primaries. Now, in terms of trying to distinguish those, I think it depends on the individual case. In the endometrium, I think if you can find a background of serous intraepithelial carcinoma, that would be one thing suggesting that the endometrium might be the primary. In the tube, if you can find a stick, again, that would be one thing suggesting that this would be non-endometrial in origin. Something that's very useful to do is immunohistochemical stains for WT1. In the literature, the vast majority of fallopian tube and ovarian and peritoneal high-grade serous carcinomas are WT1 positive, probably on the order of like 90 to 100% of cases. For endometrium, the vast majority are negative, but you have to be careful that a very small subset can be WT1 positive. It's probably going to be less than 20%. And usually your extent of expression tends to be a lot greater in ovarian and fallopian tube, and your extent of expression tends to be more limited in endometrium. So if you do immunostains for that, that can potentially separate one from the other, but you have to be prepared that sometimes endometrium can be positive. And so sometimes the WT1 can be helpful if it's very clear-cut. In other cases, sometimes it might not answer the question. And so like I said, it kind of depends on the distribution of disease. You're finding other incidental things like maybe an intraepithelial carcinoma in either site, and then also inclusion of WT1 immunostains, and that's typically our approach to handling those cases. Now, we do have some cases where you will have bulky disease in either site, and in those cases, we'll base on our pathology reports, we'll just say, high-grade serous carcinoma involving fallopian tube, ovary, and endometrium, see comment, and then in the comment, we'll basically tell the clinician what the differential is and what we did to resolve it. But in this particular case, we can't tell is it one or the other, and our clinicians understand that that happens. And I think from a management standpoint, that's not going to be a highly crucial distinction, because in either case, it's going to be a high-stage, high-grade serous carcinoma. They're both going to have aggressive behavior, and they're both need to be treated equivalently. So if you're stuck in that situation, I think the gynecologic oncologist understand that dilemma, and it's probably not going to be highly critical for them. So that's probably the majority of the situations we encounter. Another corollary to that, I think it's worthwhile pointing out, is that occasionally, sometimes we'll get endometrial biopsies where we have small detached fragments of a serous carcinoma that superficially you might easily assume this is an endometrial serous carcinoma, but ultimately it was really an ovarian or peritoneal or fallopian tube high-grade serous carcinoma that had small detached clusters of tumor that was exfoliating through the lumen of the fallopian tube into the endometrium. So that's another pattern of involvement that sometimes we see preoperatively, and it's useful to be aware of that, because if enough red flags get raised, you can then do a WT1 stain to potentially suggest that origin. So that's just something else to keep in mind, that occasionally we will see that present in a endometrial biopsy, and I hope that answers that question.
Crystal clear. Well, you could take another sip of your coffee. We're about halfway through the questions, and here's a question from Dr. Ali that I was kind of wondering about myself. Dr. Ali asks, in patients with serous ovarian carcinoma, what is the interpretation of finding only psammoma bodies without epithelium in omental sections? Does it have any significance that perhaps the patient already received chemotherapy?
I guess one question to ask is, are you specifically talking about high-grade serous carcinoma or low-grade serous carcinoma?
It doesn't specify, just serous
no
ovarian carcinoma.
Well, I'll answer both. If it was a high-grade serous carcinoma, and then in staging biopsies, all we see is psammoma bodies, and we don't see any tumor epithelium, then we'll diagnose that as such. We'll just say psammoma bodies negative for tumor. Even if we see psammoma bodies, we won't call it tumor unless we actually see tumor epithelium there. Now, you raised a question about chemotherapy. It's certainly possible that you may have had a patient that had very bulky, unresectable disease. They gave the patient a couple cycles of chemotherapy, and then they do the debulking procedure, and sometimes you will see chemotherapy effect in the tumor. And even in that setting, even if you just see psammoma bodies in the omentum, we're still going to handle it the same way. We're still going to say psammoma bodies negative for tumor. And I don't think that's going to be a highly crucial thing, because in that if that was the setting, the clinicians would have known that the patient already started off with a high stage, high FIGO stage. So I don't think that's really going to cause any problems for the clinician, because that would have been the situation that you would have started off with bulky, unresectable disease. So for the high-grade serous carcinomas, as I said, we'll diagnose it, based on what we see. For if it's low-grade serous carcinoma, Same thing. We'll handle it the same thing. But the reason I asked that question is that there's the suggestion in the literature that for serous borderline tumors as well as low-grade serous carcinomas, that sometimes you see this finding in the fallopian tube that's called papillary tubal hyperplasia, and some authors have suggested that potentially may be the origin for some serous borderline tumors or low-grade serous carcinomas. And in that papillary tubal hyperplasia, you'll have marked papillary change of the tubal mucosa, epithelial stratification, detached benign epithelial clusters, as well as lots of psammoma bodies. And what we've seen in some cases is where you have papillary tubal hyperplasia of what I just described in the fallopian tube, and you don't see any ovarian tumor whatsoever, and you'll see lots of psammoma bodies in the omentum and lots of endosalpingiosis. So if you get a case of, for example, low-grade serous carcinoma, and you see a lot of psammoma bodies in the omentum without any tumor epithelium, that doesn't necessarily mean that that was metastatic carcinoma. That could have potentially been coming from the special papillary tubal hyperplasia that can be associated with psammoma bodies. So to definitively answer your question, if you have a low-grade serous carcinoma and you have psammoma bodies in the omentum and there's no tumor epithelium, we just diagnose it as psammoma bodies, negative for tumor. Now, how it got there, it's theoretically possible that you could have had metastatic tumor that has a burnt-out focus and you no longer see epithelium, but there's no way for us to prove that. We'll just diagnose what we see. But in light of this recent finding of papillary tubal hyperplasia, having psammoma bodies in the tube and in the omentum and having no ovarian tumors, if you encounter those psammoma bodies in the setting of low-grade serous carcinoma in a non-ovarian site and there's no tumor epithelium, that definitely could have been something originating from the so-called papillary tubal hyperplasia. So again, to answer your question, if you have a low-grade serous carcinoma and you have psammoma bodies outside of the ovary and there's no tumor epithelium, we just diagnose it as psammoma bodies present, negative for tumor. So I hope that
ovarian surface involvement.
I'm not. Can you clarify that question? I'm not sure exactly what he's getting.
Also, that's why I read it verbatim. But
Okay.
what I think he wants to do is to clarify perhaps any differences in origin or anything else between the fimbriated end of the fallopian tube and the ovarian surface epithelium.
Okay, I just want to make sure I'm understanding the question. So are you asking, in the case where you have a stick in the fallopian tube, is there a role for determining whether there's tumor positive on the ovarian surface epithelium? Is that what you're asking? Or did I totally miss
seems that way. It seems that way, Russell. Yes.
Okay. If that's the question, then yeah, definitely it's really important to make sure whether there's tumor involving the ovary. So for example, if this is a prophylactic specimen and you have only stick as your only finding and there's no tumor anywhere else, then that would be tumor confined to the mucosa. And in that setting, like I said, the clinician would be hesitant from giving chemotherapy. But in that same setting, in addition to stick, if you also had tumor involving the ovarian surface epithelium, that would then change the stage to a stage 2 lesion, and that patient would be fair game for chemotherapy. So in that type of setting, yeah, it definitely would be important to make sure that the ovarian surface epithelium is negative and that your stick is confined to the mucosa. So I hope I understood what that question was really asking.
I think so. I see another question from Dr. Giulati, but it seems to be identical from a previous one, so I'll skip over it. And here's an interesting question from Dr. Chen. He said, is there any way to diagnose or differential diagnose a primary peritoneal serous carcinoma from an ovarian serous carcinoma?
Yeah, the traditional criteria that's been used is the Gynecologic Oncology Group, or GOG criteria. And basically what that, in very simplistic terms, if you have involvement of the peritoneum and the ovary, and you're trying to determine is the serous carcinoma a primary ovarian origin or primary peritoneal origin. Basically, in very simplistic terms, what the GOG criteria states is that if your focus involving the ovary is smaller than 5 millimeters, then it's consistent with peritoneal origin. If it's 5 millimeters or greater, then it's ovarian origin. And that's the traditional criteria that's used by probably most people. If you look in all the textbooks, that's the criteria that's constantly cited. And one thing I'll point out is that those criteria are totally arbitrary. They've never been scientifically validated. And then in light of this new paradigm about probably all high-grade serous carcinomas potentially coming from the tube, that would probably mean that really that distinction is actually moot, that was probably a, primary peritoneal case where somebody, couldn't identify the precursor in the tube. But to answer that question, the traditional criteria are the GOG criteria that uses a 5 millimeter cutoff for the focus that's involving the ovary.
Okay, thank you. There's a couple more questions, and I'm going to add a couple zingers of my own. We have Dr. Ahmed asking, just wants to clarify, I believe, if there could be a simple way of just defining the difference morphologically between invasive and non-invasive implants.
Yeah. So in very simplistic terms, between invasive versus non-invasive implants, what you want to see is infiltration of underlying tissue, provided that you're not mistaking that for a desmoplastic non-invasive implant. So really the main thing to look for is something that qualitatively looks like an invasive low-grade serous carcinoma, except it's a very small, these tend to be very small foci. But in very simplistic terms, that's what you want to see is irregular infiltration of underlying tissue. And again, it looks like an invasive low-grade serous carcinoma, but just a very small focus.
Okay, that does it for me. I have a final question here in the chat box from Dr. Liu again, and he asks, do you use the term intraepithelial carcinoma in borderline tumors, and should treatment for them, should they be treated as invasive high-grade serous carcinomas?
Okay, I just want to make sure I'm totally understanding this. Can I get you to please just repeat that once more?
Okay, I'll read it verbatim. And
yeah, sure.
The first part seems pretty easy. Do you use the term intraepithelial carcinoma with borderline tumors ever?
Okay, so for the first part of that, the only time we would use the term intraepithelial carcinoma if it's something like a mucinous borderline tumor. So for mucinous borderline tumor, intraepithelial carcinoma is a recognized accepted terminology. For the serous carcinomas, particularly for the low-grade, or for serous borderline tumors, we typically don't use the term intraepithelial carcinoma. What's conceptually the equivalent of intraepithelial low-grade serous carcinoma is basically what's traditionally called micropapillary serous borderline tumor. At Hopkins, we're kind of one of the outliers. The term we use for micropapillary serous borderline tumor is non-invasive micropapillary or low-grade serous carcinoma. So that's the term we use, but that's a synonym for micropapillary serous borderline tumor, but we really don't use the term intraepithelial specifically for the low-grade serous tumors. And was there a second part to that question?
Okay, thank you. Doctor,
was there a second part to that question?
no, I think you answered it clearly, in my opinion.
Okay.
But I did cook up a couple questions of my own. And something I was kind of curious about during your presentation, you kept talking about the fimbriated end of the fallopian tube as being the hot spot. And I'm just wondering, is that simply because there's more surface epithelium, or because of its proximity to the ovarian surface? Is there any intrinsic reason why the fimbriated epithelium would be more susceptible to these genetic mutations than, let's say, the isthmus epithelium or the other portions, the ampullary or intrauterine?
Yeah, that's a very good question. A couple of comments. I think just to summarize, I think at this point in time we really don't know why that is, but I think that there's a couple of things that suggest what might be going on. Pat Shaw is a gynecologic pathologist from Canada, and her group had a previous study where they did a gene profiling study looking at normal fallopian tubes from various subset of women. And what they showed is that in women that were in the luteal phase, that they had certain molecular signatures that were more in common with what you see in high-grade serous carcinoma compared to in the proliferative phase. So there may be something hormonally potentially going on there in the fimbriated end, and there may be something that might make that molecularly more susceptible, but we really don't know, but there's the suggestion that there's something going on there at the molecular level. Now, another thing to consider is that since the fimbriated end is sitting right on top of the ovarian surface epithelium, and we know that there's some type of correlation between ovulations and risk for ovarian cancer. So, for example, women that go on OCPs to reduce ovulations, those women clearly have lower incidence of ovarian cancer. And in animal models, I think it's hens or something like that, that produce a lot of eggs, they have very high frequencies of cancer. So I think that considering that there's some type of genotoxic injury that's probably occurring in the fallopian tube mucosa, considering that the fimbriated end is sitting right on top of the ovarian surface epithelium, and with repeated ovulations and potential damage occurring at the level of the ovarian surface epithelium, again, with the fimbriated end sitting right on top of that, potentially it might be that type of injury and damage from ovulations, repeated ovulations over a lifetime, that potentially damages selectively that part of the fallopian tube that results in mutations. So that's one idea that potentially might be happening, but that's not proven, and we really don't know why the hot spot is really in the fimbriated end, other than to say we know the fimbriated end is a hot spot. But those are some ideas that potentially might explain it, but it's not proven, and at this point in time it's not really known.
Thank you very much, Russell. I have kind of another interesting observation that I noted during your presentation.
Sure.
I teach the global pathology course, and they talk about all of the INs, like, CIN, PIN, VIN. And I just want to know, who is the joker that decided to call stick with the IC at the end rather than the IN at the end?
Yeah. Well, a lot of the initial pathology work for stick came out of the Brigham Hospital, and when they had initially started doing a lot of studies describing this, they were referring to these as TICs, tubal intraepithelial carcinomas. And at that point, I don't think it was recognized that there were really, atypical lesions less than TIC. I think it was thought that since these were high-grade lesions, they just basically, pop up. So I think it was assumed initially that, there's just intraepithelial carcinoma, and then as it was recognized that these were highly linked with serous histologic type, these then became stick. So I think that terminology got really entrenched in the literature before we started really recognizing that, there's atypical lesions that are, less than stick. So I think that that's kind of like that inertia that's built into the literature would make it really difficult to change. And I think it wasn't until we, as the pathology community, really started finally, looking at these fimbriated end fallopian tubes and doing immunostains that we really started appreciating that there's these atypical transitional, type lesions that are less than stick. So I think by that time, stick was really entrenched in the literature. I think another potential reason to explain that is that, since these are high-grade lesions and that these probably evolve very quickly, and it's not like, cervical CIN where it's kind of like a long, progression sequence, I think that probably a lot of people might have problems with accepting that there's kind of like a slow progression pathway like you see in dysplasias of the cervix. So I think that might be one issue that some people might have. But to answer your question, I think stick basically just got, initially, established as a terminology, and it wasn't until after that we started recognizing that, there are, lesions that we see that are less than stick. Another thing I can see some people having problems with is, like I was alluding to in the lecture, is that, since there's not really any standardization for criteria of stick and things like that, and all this work is relatively new in terms of achieving some standardization by, recognizing that there's an atypical group, and then that there's stick, and then that there's normal. I think if you're trying to introduce an intraepithelial neoplasia grading system, you're going to obviously be adding in additional categories, and I think that's going to create a lot of problems with reproducibility, because like I showed, having it as simplistic as we have of just, stick, an atypical lesion, and then normal, and then a P53 signature, just having those choices, your reproducibility is not perfect. So I think if you introduce an intraepithelial neoplasia grading system where you have a lot more grades, I think since you'd have more choices available, there will be additional reproducibility problems. But again, just to summarize your question, I think since that term's already been established in the literature, I think since there's been so many disagreements in the literature, especially in the last WHO meeting, for which these terminologies are going to be coming out next spring, I think considering all the bickering that was going on at the WHO, I think if anybody was to try and introduce an intraepithelial neoplasia grading system, I would presume that there's going to be even more disagreement in that. So even though theoretically and conceptually you might have an idea there to parallel what's been done in other organ systems, I don't think it's going to happen considering everything that's occurred up to this point with stick. So I hope that answers that question.
It certainly does, and since we have started to count down here, we do have an additional question from one of our outstanding global medical students, Dr. Zhairov, and he asked the question, is there any correlation between stick and estrogen level?
Between stick and estrogen level, I'm not sure I can really answer that question. It's probably a more clinical question, and I am aware that there have been some clinical epidemiologic studies that have looked at risk factors for women that have stick in terms of, parity and things like that. And I know there are some papers published, and I think they're probably published in Gynecologic Oncology. I know that some epidemiologic studies have been published. I think some of these may have actually came out of the Brigham Hospital, and I honestly cannot remember the findings from those studies, and I'm sure that they made some types of correlation with certain clinical parameters, but I honestly cannot remember if there was anything that was necessarily established between a link of estrogen levels and stick.
Thank you again. Dr. Vang, I wanted to thank you for staying late and answering all these questions, but I also wanted to remind our attendees that this webinar technology is very sophisticated. So if any of the attendees have their microphones plugged into their computer, or they have a laptop where there's a built-in microphone, there's certainly a mechanism for you to just press the button on your control panel, and you can ask Dr. Vang a question without me doing the intermediate translation. So I'm going to be looking right now, I'll give it about 5 seconds or so. I'm going to be looking at the list of all our attendees who are still here. They have the same patience that we did and the same level of enthusiasm. And I don't see any hands that are raised right now. And that's okay, because most people still prefer the chat questions. So having said that, my job is over, and I'm going to turn everything back to Brandon. Thank you very much.
Thank you.
Okay. As Dr. Minarsik said, thank you, Dr. Vang, for staying late. And judging by the amount of attendees that stayed through a Q&A session, I would say probably 95% of our very well, we had a great influx of attendees today. It's a very high number today, and about 95% of them stayed through the Q&A. So I think I can speak for them when
Great, excellent.
I say that it was a wonderful lecture, excellent insight, very practical subject, and I think you answered many pertinent questions that needed to be addressed. So, again, I think I speak for them when I say thank you for being here today.
Great. Thanks for the invite, Brandon.
Of course. Yeah, it's been great working with you, and hopefully we can do something again in the future. I know you have plenty of lectures, subjects that you like to talk about, so perhaps we can schedule something in the future. We're going to go ahead and close.
Absolutely.
Okay, very good. I'm going to close the lecture here by reminding our viewers that it is recorded. We'll be posting it on GoPathDX.com hopefully this afternoon. I think I can get that in. And I would like to emphasize to our members that it's a free educational portal, so any input and support is always welcome and encouraged. You can donate by clicking on the donate button on our website at the bottom of each lecture page, and you can find it throughout our website. If you'd like, we're trying to boost our case forum as well, so we encourage people to send any interesting cases to cases@GoPathDX.com, or you can post them directly on the Case of the Week forum. And further, if you have any feedback or suggestions, of course, you can contact me, bcornell@GoPathDX.com. My contact information's all over the website. Once again, I think that concludes the webinar. Dr. Vang, it's been wonderful working with you, and thank you again this morning. I know everyone appreciates your time, and I look forward to working with you in the future.
Okay, me too. Thanks a lot, Brandon.
Okay,
should I just go ahead and close out everything on my screen now?
Yep, close it out. I'm going to end the webinar now, and thank you to all the attendees for being here this morning, and thank you, Dr. Minarsik. Okay.
Okay, thanks, Brandon.
Thank you.